Hello, and welcome to the Body Fusion Therapy Podcast. I'm your host, Dr. Heather Demirci. On today's episode, I'm going to be talking about scar tissue and adhesions. Within a session with one of my patients, I say the word either scar tissue or adhesion, I'm guessing at least 5 times. And at the beginning of my treatment sessions with the patient, they're usually asking, what is scar tissue? What are adhesions? And wondering what the difference is and what they are. So in today's episode, we're going to dive a little bit deeper into that so you can understand what the adhesions are and why they're a problem. So in my objectives today, we're going to discuss the difference between scar tissue and adhesions, how they are formed, why they're important, and then finally, what can you do about them? Often you will hear healthcare practitioners using the terms scar tissue and adhesions interchangeably, and they are very similar, but there are a few differences. Scar tissue is a collection of cells and collagen that covers the site of an injury. So this injury would be a surgery, so the surgical scar, so you'd see that on the outside, and also the repair of what the surgery did on the inside, that would be considered scar tissue. Or if you had a big injury where you cut a part of your body, that would form scar tissue. Or internally, if you had a big tear of a muscle, I would consider that more scar tissue than I would an adhesion. An adhesion is an abnormal union of membranous surfaces due to inflammation or injury. So the key word with adhesions is inflammation. So it doesn't have to just be an injury. And it's kind of a union between membranous surfaces. So it doesn't necessarily mean that there's always new tissue that is created. It is in some cases, there might be little ones, but not to the extent of scar tissue. Scar tissue is going to be producing a lot more tissue. Adhesion sometimes is just the surfaces touching and not coming apart. The difference between the two is more about what caused it, not necessarily what the end result is. Because in most cases, the end result is this new collagen in this area, this new kind of membranous tissue that is there. This new collagen, this new membranous structure, now it's not like normal healthy tissue. Healthy tissue has this nice linear pattern, and it has a lot of tensile strength to it. So that means that you can twist it, bend it, stretch it, squeeze it, and it will, for the most part, maintain its shape. It has good mobility and good elasticity. This abnormal tissue from scar tissue and adhesions is different. It's more like a cobweb. It's this abnormal alignment that's kind of all over the place. It creates like a patchwork to be able to cover the site of injury, because when it's trying to repair something, it's not worried about if it has this nice kind of linear, high tensile strength tissue that it's laying down. It's more just trying to cover an injury and make it so that the injury doesn't occur. You don't continue to bleed. There's no more damage that happens there. So it's not the same type of tissue, but your body can't tell the difference between this cobweb-like structure and this linear, healthy tissue. How is this new tissue formed? Well, when there is tissue damage or inflammation, then there kind of starts this inflammatory response that occurs. Within this inflammatory response, there are fluids. And these fluids contain repair cells that are patching it all up, and it lays down this new tissue. Now, when you have this site of a surgery, remember, it's not just external scars. Sometimes people think that just because they had an arthroscopic surgery or a laparoscopic surgery where it's just a tiny little incision, that nothing really occurred. It's just right there on the surface. They're like, oh, it was a small incision, so inside it's probably small too. That's not the case at all. They're poking and prodding through the tissues, through the different layers to get to the site that needs to be repaired. Yes, they didn't have to open a large hole to get there, but there's still a lot that's going within the abdominal cavity. I especially say with this arthroscopic surgery, scar tissue of that is like Spider-Man's web. It comes from a small little slit in his wrist, but then when it shoots out, it goes in all different directions. So don't just assume because you have a tiny little scar on the outside from a surgery that the inside is also tiny little scar tissue. It could be this huge patchwork of abnormal tissue lying and connecting these different areas that could be causing part of your dysfunction. So don't just assume just because it's a little scar that that's what happens on the inside as well. Because really, the majority of that work from that surgery was done on the inside, not the outside. And the scar tissue lying down is evidence of that. Now, if the surgery was an open surgery where they had to make a bigger incision, you're going to have more scar tissue. But sometimes more scar tissue is actually just on the surface than it is internally. I have seen people that have had laparoscopic surgery or arthroscopic surgery where inside the adhesions and the scar tissue are way more vast than what I've seen with someone that has had a open procedure where they've had to make a bigger incision. So don't just assume that because it was small that the inside is small too. And don't assume just because the outside was a big scar that the inside has a lot of scarring as well. It just really depends on the person. And you can also tell from the quality of the scar that you have on the outside what kind of could be happening on the inside. Have you ever seen a scar that's really bubbled on the outside? This could be a keloid or just a hypertrophic scar. Basically, it just says that there's a lot of excess scar tissue that is formed. Now, if someone has those big keloid scars, that's not great for what's happening internally because it's going to kind of tell you what's happening on the inside as well, that they probably produced a lot more scar tissue than someone that has a really nice shallow line where you can almost barely tell that they have surgery. Like I have patients that I can't even see the old site of their surgery because it's just the tiniest little scar that is healed so well. Well, for me, actually, I keloid in my scars, and you can see on my shoulder, I've had 3 shoulder surgeries, and you can still very vividly see the 5 little tick marks that I have on there for where they put the inserts of the probes. So I keloid in my scars, and then that means that also I produce a lot of scar tissue on the inside as well. So you can kind of tell what sort of scarring someone will have based on what a scar on the outside of their body looks like as well. Now, adhesions elsewhere in the body are often caused from an immobility. Either that's an immobility within the structure itself or between different structures. So we have something called the interplay between muscles and within muscles themselves. So there's a lot of fibers and fascia going all throughout the muscle itself, like a quad muscle. And within that muscle itself, there can be adhesions. There could have been abnormal tensions. There could have been a small injury that occurred, and those tissues kind of seized up a little bit, and the repair process left a little bit of this cobweb. So the muscle itself doesn't move very well. You can also have a decrease of interplay between muscles, where there's adhesions between kind of sets of muscles, or between like the quads themselves. The quads, there are 4 muscles. That's why they're called the quadriceps. And each quad muscle needs to be able to move individually. If they weren't meant to move individually, then they would just be one big muscle. There's a reason why you have all these different muscles in your body, because they're pulling and tensioning in different angles and different force vectors that allow your body to move. So you need to have mobility between the muscles as well, not just within the muscle. So adhesions are more the problem in this area when the muscle groups are stuck together. Now, adhesions within the abdominal region are a little different. So about 70% of your immune system is within your abdominal cavity. That's a lot. And remember, it's that immune response that leads to the formation of these adhesions and this extra collagen and the different kind of membranous surfaces getting stuck together through these abnormal unions. So if you have an increased inflammatory response, it's going to lead to more adhesions. If you have all of those different cells and fluids right there, ready to go, then the response is going to be even greater. So we usually find adhesions within the abdominal region to be more pronounced and more of an issue. But the way they come around is a little bit different. So one way is trauma, which is the same part of any part of your body. Any sort of trauma can cause adhesion or scar tissue. But traumas that we'll see within the abdominal cavity, so like with car accidents and seatbelts and how the seatbelt crossed over your body and say you got T-boned or rear-ended, that pressure, that quick kind of push on your body of the seatbelt can actually cause an inflammatory response that will lead to adhesions. Or if you fall, even falling onto your bottom, there's a reverberation through your abdominal cavity. The abdominal cavity is very liquidy. And so as you kind of fall down, you'll get this reverberation, these waves going through the abdominal region. And that can also lead to an inflammatory response that starts to get things adhered. So we'll see this a lot with people that fall often. I grew up in a ski town in Colorado, so a lot of people falling from ice or while they're on the mountain skiing as well. And that could be leading to adhesions through the abdominal cavity. Pregnancy can be an internal trauma that's happening, right? All the kicking and punching that's occurring when the baby's in the belly will do the same thing. Like I've said this before, but my daughter, when I think I was like 24, 26 weeks pregnant, she actually kicked and it completely obstructed my gallbladder. So yeah, there's a lot of internal trauma that comes with pregnancy too. There's a lot of adhesions that are formed when you're pregnant and the fetus is moving around and kicking and punching its way through. Another type of adhesion that can be formed in the abdomen is from a food sensitivity. So like I said, 70% of the immune system is in the abdominal cavity, and 70% of that is within the small intestine lining itself, because it's there to make sure as the food's going through that you're not eating anything that's poisonous or harmful to your body. Otherwise, it will make you get rid of it as fast as you can, either through vomiting or for diarrhea. So if you have a low-level food sensitivity, then adhesions will be formed. It will just cause this inflammatory response and you'll get a lot of adhesions through your abdominal cavity. I usually tell my patients that if I'm treating through their abdomen and I break up the adhesions and then they keep coming back again, that we need to get them tested for food sensitivities. It might not be a food allergy. It might just be something that they're a little sensitive to that's causing this inflammatory process that's leading to the adhesions that's making their dysfunctions worse. Finally is this idea of immobility. Now, I talked about immobility elsewhere in the body, but it also happens in the abdomen. And in the way it works in the abdomen is just a little bit different. There's a lot of liquid, like I said, through the abdominal cavity. So if you think about the analogy of taking a glass of sweet tea or something, a sugary drink on a hot day and putting it down on the coffee table, there's a lot of condensation around there. But if you don't move it, if you let it just sit there, then eventually that condensation on the outside of the glass dries and the glass sticks to the table and it's hard to pick the glass up and it almost leaves a ring on your coffee table. The same thing can happen with the abdomen, especially in the pelvic girdle. So if you think about if people are sitting all day long, which we're in a society that sits all the time, that the inside of your pelvis is just staying stuck in that position and it's just getting dried there. It doesn't need to move. There's no liquid passing through that area. And so there can be a little bit of drying of that and connection, this union of membranous structures that's more with the adhesion type of formation of abnormal tissue. So immobility will do that as well. Elsewhere in the viscera, if you don't have the diaphragm working well, that can also lead to this immobility adhesions as well. So if the diaphragm is functioning properly, the kidneys will actually move up and down over an inch with inhalation. So having good diaphragmatic mobility and breathing with your diaphragm rather than sucking in your abdomen all the time allows the viscera to kind of keep this flow and moving so you're not having issues with immobility and causing these immobile adhesions. So why is this scar tissue and these adhesions such a big deal? Well, your body can't tell the difference between healthy tissue and abnormal tissue. It just views it as tissue. And so you'll start to have inhibition of motion because of these adhesions. And if you remember back to my episode talking about hypomobility versus hypermobility as or part of the root cause of your pain, if you have these adhesions through your abdominal cavity or adhesions through your hamstrings, wherever these adhesions are, the scar tissue, you'll create an area of not enough motion or of hypomobility. And then you'll have other areas that are creative hypermobility and too much motion, which usually ends up being the site of pain. So we need to get mobility through these adhesions and scar tissue so that there's this healthy transference of motion and also core strength can occur. There's a lot of patients that I'll see with low back pain that have really poor core initiation. Their core's not firing to help protect their lumbar spine, their low back, and it's because adhesions are making it so that then their muscles aren't able to contract in their core to then stabilize the spine and create this pressure system that's going to make it so they don't get injured. So we need to be able to clear up these adhesions and get them moving. They're not healthy. It's unhealthy tissue that was there, and it was there for a reason. So unless you have an active bleed or an active injury going on at that site, we're not going to be touching it. I'm not going to be moving it because it needs to be there to kind of patchwork the problem. And then once the initial injury is kind of covered and healed, now let's get the mobility back where we can. So we'll see patients that have had scars. And this is why I ask about any surgeries at all, because this has this potential to make scar tissue throughout the entire body. Or, what is their digestion like? When I ask what their digestion is like, which I ask every single patient that, is if they have bowel movements regularly every day, that tells me how their viscera is able to move and if they have adhesions within their abdominal cavity. Because if they're having issues with bowel movements, if they're not regular every day, it could be because there are adhesions that are holding back the ability of the intestines to move the food along. So it's a big kind of picture of how the body's functioning. So I want to know about surgeries. I want to know about bowel movements. I want to know if there's any prior injuries that could lead to these adhesions. And then we need to go after these adhesions. Now, people are usually worried when we say that we're going to go and break these adhesions up and wondering, well, how do you know that you're breaking up the bad adhesions and not hurting the good tissue? Well, because the good tissue has really strong tensile properties, right? I said like you can bend it, twist it, like your body can move in all these crazy ways, especially if you work those tissues and really try to stretch them. It's amazing, what some of these yoga people can do in terms of their mobility through their entire body. So tensile tissue is extremely strong. That healthy tissue is meant to move. It's this abnormal kind of cobweb matrix that's going through the body that's what needs to move. So my job is to go after those tissues and get them moving through and kind of breaking up the cobwebs. Now, obviously, breaking up new, fresh cobwebs is a heck of a lot easier than breaking up really old cobwebs. So the longer you've let scar tissue stay there, so especially scar tissue, not adhesions as much, but scar tissue from a surgery, the longer that it's just sat there, the harder it is to break up because you just kind of get layer upon layer upon layer of tissue that's holding it into place and just kind of reinforcing that need, because as your body's moving and you're pulling against that tissue and that abnormal alignment, it actually will create some more scar tissue because you might be pulling a little bit on those abnormal tissues, and then it creates another inflammatory process, which then brings down the laying down of new adhesions and so forth. It's kind of this nasty feedback loop of scar tissue adhesion formation. So we have to be able to stop that. We need to get it moving. And the best way to do that is through mobilization of those tissues. So your next question might be, well, how do we do that? Well, let's get to the treatment aspect of this. A couple ground rules when it comes to mobilization of adhesions. One is you don't want to create a new inflammatory process that's going to lead to more scar tissue or adhesions being formed, right? We want to avoid the inflammatory process. So some patients will ask, well, how do you know that you're doing enough pressure that will break up the adhesions but not cause this inflammatory process to create new adhesions? And with that, I say that you have to be very localized in how you're treating through those tissues. And even when you're doing your own self-mobilization, is you really want to lock it up. We want to lock up that tissue adhesion 3-dimensionally. It needs to be the right depth and direction that we're going at, and then doing movement around it to help kind of break it up. And so if you wind it up really good, it doesn't take much force to break it apart. So like if you were to see a cobweb or a spider's web, if you were to go right into the center of it and then do the motion, the whole thing would fall apart. Now, if I just went to like the outside of that spider web, if I just touched just one of the outside strings, I'm not going to get it all down. I'm going to have to do a lot more force to pull it down into the directions. So you really want to be localized as much as you can so that there's as little force as possible to break up the cobweb. And if you use just a little bit of force, even though for the patient or for yourself, if you're doing it on yourself, it might feel like a lot of force because it's really painful. It's just because you wound it up so much. I always say that if you look at my fingers barely ever have kind of white nail beds because I'm not pushing very hard. I'm just really making sure that I'm localized to the best ability to lock up that adhesion so that I can get it to mobilize and move without putting too much pressure through there. So that's rule number one, is we want to make sure that we're not doing too much force. You don't want to be too mean to yourself. And sometimes I'll have patients say like, no, it's okay. You can push harder. I can take it. I'm like, yeah, you might mentally be able to take more pain, but we're going to be being counterproductive here because if I push too much, too hard, your body's going to revolt and have this inflammatory process. And then all this work that we just did is going to be for naught because there could be a potential for more adhesions and more scar tissue to be laid down. Now, with scars specifically, you never want to work at the ends of a scar, like a surgical scar, or if you had like a laceration to the skin, you don't want to work at either end of that scar for the first 6 weeks. Research has shown that actually mobilization of the ends of scars within that first 6 weeks of the injury will cause a hypertrophic scar to occur. So we want to stay away from the ends of the scar for the first 6 weeks. Now, with laparoscopic scars, you might be like, well, they're like a centimeter big, so how do we do that? With that, you're just going to be going and pinching the two ends of the scar together and just moving it in a perpendicular motion to begin with. I don't really do a side-to-side parallel motion with that scar. I kind of just go perpendicular, and then you're not going to be causing this increased tension at the ends of the scar that's going to lead to the laying down of extra scar tissue. So you just want to be able to pinch the scar together and move it perpendicularly up and down to help mobilize the tissues underneath to try to avoid any sort of adhesions occurring there. Now, you need to talk to your doctor. So if you're having a surgery and you say, well, I want to get that scar moving. So I talk a lot about this with C-section moms. They want to get that scar moving, and it's really important they do start to get it moving. But you need to talk to your doctor first in terms of what they are comfortable with the scar tissue mobility, because they know what happened on the inside and they know what is going to be appropriate and what's not. So they'll give you a time frame of when you could start doing scar tissue mobilizing. Now, my biggest pet peeve with this is that people start pulling and pushing in all different directions. No, if it's a fresh scar, even within the first 8-10 weeks, especially as the patient, I just want you pinching the ends of the scar together so we're not going to be risking that scar opening, right? We want to pinch the ends together so that there's no risk of that opening. And you're just going to lightly move it around because it's in that first 6 to 8 weeks that new tissue is going to be lied down. And we just want to make sure that there's better mobility, that it doesn't scar down really tight, that there's increased range of motion of that new tissue so that hopefully it won't become an adhesion or increased scar tissue that we need to worry about down the road. So just move it a little bit perpendicularly, pinching it together. It's really important you pinch it together. Only when it's later on can we really kind of stress the scar tissue a little bit more and move it in different directions. But that first bit, when it's just laying down and healing, that kind of modeling phase of the tissue, we just want to make sure it has nice general mobility. And then later on, you can get more deep and more exact with how you mobilize it. But just getting it to mobilize at the beginning is important. It will also decrease the sensitivity of the scar. So some people say their scars are really sensitive and hard to touch. But if you start touching it early, it starts to desensitize that kind of neuro input to it and makes it easier to mobilize later. And also too, if it's been a kind of a trauma that scar was occurred, then it's good to start to put your hands on it to start to kind of come to terms with the fact that there is a scar there and now. I have patients that are really uncomfortable with their scars being touched. And there's a big psychosocial component to that as well that needs to be addressed. And so I tell them if they don't like having their scar touched by anybody, then they need to start touching their scar. They need to start desensitizing that area and dealing with those emotions because that's going to be inhibiting how their body can heal if we have this emotional component that's kind of this blockade in terms of your ability to see that area and understand that area of your body. We need to start improving that neuro input there as well. So that's kind of with scar tissue. Like, what do we do with scar tissue? Get it moving, be careful of timing, be careful of the ends. In terms of adhesions, we need to get those adhesions moving. Now, I love foam rolling. I think foam rolling is great for the middle of the muscles. That can kind of help with that interplay between the muscles, getting in there and kind of digging it out, doing some kind of self-massage, kind of stripping techniques. People talk about Graston. Graston's great for more kind of superficial adhesions in through there. And then massage and the soft tissue mobilization that a physical therapist can do as well, just getting into that deeper layer. Like I said, the important thing is that if you are doing this even to yourself, like I do telehealth, and when I'm doing telehealth, I'm trying to explain to the patient how to get to that adhesion that I can see when they're moving. And so it's about really trying to localize so that you get it tied up as tight as you can so there's not as much force you have to put through your body. So if you're the patient or if you're the therapist, really challenge yourself to think like, okay, if I push here, is this the hardest spot? What about if it's over here? What if I turn my hand a little bit? What if I kind of go to the right, go to the left? Really play around to try to lock up the tissues of that cobweb of those adhesions and scar tissue to be able to release them. And then in the Institute of Physical Art, we like to do some sort of active movement with it too. With doing this active movement, you're starting to activate the muscles. And with the activation of the muscles, then you're starting to kind of refresh this part of your brain called your sensory cortex or your homunculus. So it's getting multiple components at the same time. So rather than just being passive about it, really becoming active and doing some sort of movement where you're going into pressure on, pressure off. So when you hold and stabilize whatever restriction you have, just hold and maintain it, and then move in a direction that increases the tension underneath your fingers, and then come out of that, go in and out of that, and kind of try to improve how far you can go into that range of motion as that adhesion starts to break up. Now, if there's a lot of soreness after you breaking up scar tissue or adhesions, it's really important that you drink lots of water to help kind of flush that out, because you are going to be breaking up of tissues and they needs to get flushed out through the lymphatic system. Those adhesions that are being broken up, the fragments that are coming out, those are too big to fit into your bloodstream. They're going to be fitting into your lymphatic system. So you want to drink lots of water to help kind of flush it out of your system. It also helps if you increase your vitamin C intake as well. Vitamin C is really important for collagen production and healthy collagen production. So if you're really sore from soft tissue work, I say drink lots of water, increase your vitamin C intake, and it will kind of help flush everything out and you won't be as sore. I must say the one nice thing about doing a self-mobilization is that you're never really going to harm yourself too much, because you can't put yourself through too much pain because you're feeling the pain. So you're going to kind of hold yourself back from doing anything that's going to harm yourself too much. So that's the nice thing, because when someone else is doing it to you, you're feeling the pain. They're not feeling the pain per se. And you have to make sure that they know what they're doing and when is too far and when's just the right amount of locking up that tissue to help it mobilize. I hope from today's episode, you've learned a little bit more about what is scar tissue, how it's formed, why it's important, because it is a big hindrance to the mechanical motion that, the building of the house, that strong foundational structure that I want to create. Adhesions are what I'm breaking up to be able to improve the mechanics of how the body is functioning, and then we can move on to more of that muscular strengthening. So adhesions are a big part of the puzzle of how to get you back to optimal health, and it's important to understand what it is, how to mobilize it, and how it's formed. So I hope you enjoyed today's episode on scar tissue and adhesions. Thank you for tuning in to this episode of the Body Fusion Therapy Podcast. Please share it with your friends and family, as well as leave a review if you liked what you heard today. We're looking forward to continuing this journey of looking at the body. Tune in next time.